waiting it out. My name is Ilan, Kedan. I'm a cardiologist at Cedars-Sinai Hospital, at Cedars-Sinai Heart Institute. I'm here to talk about wearable technologies, and the wearable technologies that we're going to be talking about aren't wearable imaging technologies, which are in not production, but in research, in development. It's more wearable sensors, essentially. I want to provide a little framework for wearable technologies in cardiology. So I don't have any disclosures. I am a full-time practicing clinical physician cardiologist. So that means all day, every day for now 12 years. So we're talking about over 30,000 patient encounters. So that's my clinical experience, and that's my perspective. When I think of technology, I think of using technology as something that will help me help my patients. So I like this quote: "Technology is a useful servant but a dangerous master." And when I think of wearable technology, I think of what the goals are for acquiring the data. And really, it depends on who you ask. If you ask the physician, someone who's clinically in there in the trenches, rolling up their sleeves, taking care of patients, we want data that's going to help inform us of how we can take care of patients. Patients have a different perspective. A developer has a different perspective. They have different goals as regulatory bodies, and most importantly, the investors who are driving the development of these technologies at this time. So what do we use? Well, we have EKG data, blood pressure monitors, heart rate data. I could include oximetry data, and then defibrillator vests, which is actually, I'll talk about a little bit more later, but that's actually a unique sort of, a uniquely developed wearable technology that's actually delivers a therapy. But that's all there is. So bioimpedance, activity data, accelerometer data, that's really not used in clinical, that's not clinically used, and we don't really know what those data mean. So again, these are the types of data we're talking about: heart rate data, EKG data, rhythm data. And the EKG and rhythm data is very well established. It's been around, really, the wearable technology started with cardiology, with Holter monitors in like the 50s, 60s, and we're leading the way. And really what we're using is just these things in clinical, and just heart rate data, EKG data, and blood pressure data. If you want to include oximetry data, that's all we're using commercially, that's all we're using in clinical care. So why do we want this data? Well, I'm a philosophical guy. I like to think of data and care in the setting of how I take care of patients. So my goal is to maximize the agency of our three cherished limited resources when we're taking care of patients: our time, our decision-making ability, which is limited, and the amount of empathy that we can exude or exert with each person over the course of the day. And that helps us be the best version of ourselves, be the best version of physician we can be every day. So what are the goals, again, to support patient care decisions in diagnosis, treatment, acute and chronic disease management, and then prognosis, and then most preferably at the point of care. And the reason why I mention that is when you're with the patient, that's the most valuable time that you can actually influence your decision making, and there's data to support that. So basing decision making and having decision support at the point of care versus just kind of trying to recall, it'll offer you a much higher odds ratio for having a better decision making. And this is one image. We're on the imaging section. This is a handheld ultrasound data, acquired image of a left atrial myxoma that I just saw on a patient at the bedside. That informs decision making. So when this flow diagram is how I think of decision support with respect to wearable data. And you could actually apply this to several different treatment modalities. We have the action, and we acquire the data, we analyze the data, and then we use the analysis to inform our decisions, and then make modifications of our therapy or offer different treatments, and then react. And it's a feedback loop. The interesting thing about wearable defibrillators is we can short circuit that, because the defibrillator, which is the wearable device, actually provides the therapy. So it has an automated built-in decision support. It analyzes and then delivers a therapy. Very unique in medicine, and specifically in cardiology. Again, this is from our paper where we talk about decision support, whether it's for therapeutic uses or not therapeutic uses. And when we're talking about a taxonomy here, or creating a taxonomy for understanding where future technologies may be plugged in, and how we might be able to think about the data that we use in the decision support, we want to think about potentially diagnostic, management, prognostic, and maybe sometime in the future we'll have some more information about what they may mean versus the therapeutic decision support. Challenge with data: the more data we have, the more likely we are to drown in it. And our imaging colleagues, cardiac imaging colleagues, we have so much data, we have a need to have artificial intelligence to help us sort through it. Thousands and millions and billions of data points. And it won't take long just collecting heart rate data to be overrun by data points. If our hearts are beating 100,000 times a day, it doesn't take long to get to 1 billion. So how are we going to acquire these data? Well, again, we have a taxonomy for understanding how the data are acquired. So is it a passive or active initiation? So are we placing the data, placing the monitor, and then is the data being collected just by the settings in the device, or is it requiring the patient to initiate acquisition of the data? And are the data being continuous or intermittent? And it really depends. And how are the data being transmitted, or how the data being reviewed? Is it continuously transmitted and reviewed like a telemetry monitor, or is it stored and then intermittently transmitted and reviewed? Or is it a chip that is removed, like the XioPatch for a 2-week EKG monitor? The data is retrieved from a chip and then uploaded on a computer later for review. So here are some examples. Again, continuous monitors, EKGs, the wearable defibrillator, and then the interesting thing about wearable defibrillators is they generally don't transmit. They can be, it's an option, at least in the future. And then intermittent monitors like blood pressure, heart rate, oximetry, bioimpedance, and electromagnetic energy-based technologies. These are interesting, but again, in development and not in commercial use. We've worked with both of these in clinical trials. So what are we doing? So we're looking at primarily disease states like dysrhythmia, hypertension, and heart failure. Heart failure more developmental. Hopefully in the future we'll be able to have some of these data to help inform our decision making with respect to heart failure disease management. And in the future, hopefully, we'll be able to create reproducible algorithms for leveraging wearable technology for managing and diagnosing valvular heart disease, coronary disease, congenital heart disease, and even peripheral vascular disease within the cardiovascular disease field. And again, diagnosis, treatment effect, prognosis. So when I think of wearable data, I think what is going to help me better understand a patient's physiology and how the medications we give to the patients are modifying the physiology of the patient. And what's the vision? So I went to a college with a guy who became famous in ecologist, zoologist, and he has tracking devices that he places on wild animals in different environments, and he uses that data to understand the health of the ecosystems that they live in. And if I think of that as humans, well, how many times are people walking? How many lights are going off? How often are people walking by fast food restaurants? Who knows? We can maybe use these data to anticipate future epidemics because the data is bidirectional. What are our limitations? There are many limitations with the data that's currently acquired from wearable technologies. The quality of the data, if it's garbage in, you can't really do anything with it. One person's walking around oximetry heart rate is another person's in the grave heart rate walking around and oximetry. So these are physiologic outliers. There's user error, the patients don't hook the devices up properly, or they're not hooked up properly to acquire good data. The devices malfunction. There's a massive amount of volume of data. There's variability, noise versus signal, what's noise, what's signal, who owns the data, to the patients, to the doctors, payers, etc. How do we store all these data, and how do we maintain that they're secure? These are all very important limitations in our current kind of way of using wearable technology. And again, what's the goal and what are we doing? So define our goals. We want to prioritize clinical goals if you're a clinician like me, and then define the scope, what data, what questions. And I think with respect to using and really harnessing wearable technology, I think it's best to stick to the scientific method and identify a question that we would want to have answered and use the technology for answering the question, as opposed to what's happening now, which is the opposite. We have data and then we're retrofitting a question that is answered by the data that we have already. And so if we can keep with our scientific method, I think we might be able to have better utilization of these new technologies in a clinical setting. We got to limit our assumptions about how well these data tell us about what's going on in our bodies, in our patients' bodies. And we really want to maximize data to help us use our time better and help us access our empathy and increase our connection with other human beings in our care for patients. So I wanted to keep it short. Thanks for sticking around and listening. If you have any questions, I've got a couple minutes.
Osmosis.
Thank you very much, Ilan.
Thanks.
Thanks to all the speakers for this outstanding session, and for the audience, thank you for sticking around and your questions.